Good people, I'm in person today from my home city, Chicago. We're at ENDO 2026. Joining me today are the founders of Pituitary World News, JD Faccinetti and Dr. Louis Blevins. Gentlemen, thank you for joining me today.
Pleasure.
Nice.
Pleasure to be
Yes.
here.
Thank you. It's
Thank
my
you for the
pleasure.
invitation.
It's a pleasure to have you both. Let's start from the beginning. How did Pituitary World News start?
Well, it all started with this guy coming to see me in the clinic. And obviously he had Jorge has acromegaly, just as you do. And we hit it off right away as sort of a doctor-patient relationship. And then probably a month or two after, maybe even a week or two after you came to see me, I was called by one of the TV stations who said, "Hey, we hear you have interesting patients and we want to do a medical segment on the evening news. Anybody you think might be good for a program?" And I know a guy who's got a lot of charisma and is well-spoken, interesting case. So you should do it this guy. So it was about Jorge. They had me on there a few times, but it was basically about Jorge and his condition. And after that, I remember we had lunch not far from work.
No,
Very late meal after you had a visit. And he asked how he could get involved and what could we do to sort of improve awareness of this condition, because he has probably 25 to 30-year delay in diagnosis. And we got to talking, explored a couple of opportunities, and ultimately said, well, why don't we do this ourselves? And we started out with sort of a blog post, and it evolved from there. All right, you can tell them about that.
Yeah, it's funny because at first I didn't want to do the TV thing, and I think he talked me into it. But it was that, and then a few other opportunities, like they were doing a TED Talk style presentation, if you remember, at the ACE meeting in LA. But it evolved. We started getting a lot of attention with the blog that we were putting out. And then we started figuring out how to make it more effective, used a publication template, and pretty much decided to create a sort of a publishing model, like, I used to call it the Huffington Post of the pituitary world, where you can do original things and then news aggregation for patients and doctors and families to come in and learn more about their condition and work more effectively. And we're hoping and we think that it is helping in reduce the time that it takes to diagnose with the people that recognize the disease. So it's been a really interesting journey. It's been growing. Every year we're amazed at how many people come through the site and try to learn as much as possible what they do with information.
It's a very good site. I'm thankful for you guys' site. I'm already quite a bit for this site as well. Dr. Blevins, have you learned anything differently over the years of how patients with acromegaly and other pituitary disorders are misdiagnosed and treated differently?
And I have. It was obviously apparent as I was practicing medicine, but I think it's more apparent and obvious to me through the people we met with Pituitary World News. Because I think the one thing that I hear more loudly is patient needs. When you're a busy doctor, you might have 18 patients every Tuesday and Wednesday and 12 on Thursday. You kind of move through the clinic. You take as much time as you can with every patient and try to give them a voice and understand their concerns. But I think that probably if the patient knows the visit's short and time constrained, those discussions don't come out. That people might think about when they're home or whatever. But when people are writing to us or we see on social media, those things come out when they're sharing, and to me, it heightens the awareness of the fact that there is more to the patient journey than any physician is going to get through offices. So I think the voice of the patient is more powerful with the things that you're doing, the things that we are doing. And that's why I appreciate the opportunity through social media and video and, all these things to bring that to the forefront. So any physician who's watching will maybe start paying attention to Not only symptoms and sign, not only the blood tests, symptoms and signs, it assess whether or not a patient's needs are no met. So I've learned that the patient voice is loud and is clear. We just have to tune our ear into it. We may not have our ear tuned to it during the visit. So we have to pay attention to things like your group and Pituitary Network Association, Pituitary World News, the WAPO group, and all these other groups that are interested in pituitary patient care, often started and driven by patients themselves. So that's the one thing that I have learned over the years.
JD, you've interacted with hundreds of patients over the years.
Yeah.
Is there anything that you feel has been misunderstood as far as you and I both live with acromegaly?
Yeah.
Do you think that there's anything that's been misunderstood as far as patients go with their diagnosis?
That's an interesting question. Sure, I think that the diseases itself, are misunderstood unless you land in at a pituitary center where there's experience. So I think that people still just struggle with, the comorbidities that come with the disease, and I think those, you could say, sometimes are misunderstood because I don't know if the medical system is set up to handle all of the complications that come with acromegaly. But I think the biggest issue is, that these diagnoses delay.
And it takes a physician to recognize.
Exactly.
Instead of treating a guy for sleep apnea or a woman for carpal tunnel syndrome and managing their hypertension or their diabetes, you have to put it all together and recognize they have a disease state that needs specific attention. And if you take care of that, you can prevent all the complications. Some of them are which you can never fully treat the arthritis.
Sure.
Once the arthritis starts burning in, your joints are going to be going years later, regardless of whether your acromegaly is controlled. So it really takes that increased awareness. There's a really good story we share. Jorge went to his primary care physician, wanted to talk with him to say, hey, you kind of missed my diagnosis and I'm not upset about it, but I want you to know about it and learn about it from me so that you can recognize it the next time you see it. So his doctor reluctantly, I think was the better word to say,
Yes.
without sharing the details,
Yeah.
agreed, and they met and they talked. And then within a couple of months, this doctor is seeing an elderly gentleman in his office. And at the end of the visit, he says to the son, I know you're not my patient, but you look like one of my early patients, and I think you might have acromegaly. So you need to be tested for that. That patient gets the workup with another doctor, has a disease, goes to see a surgeon who says, oh, I don't see a tumor. I don't think you'd have that. Jorge says, you got to go see Blevins in San Francisco. And he was reluctant to do it. He comes to me. It's like, oh, there's your tumor. And yes, you do have it. And we cured him with surgery. So it's like people are ignorant of the disease, ignorant in a good sense of the word. There's ignorance in a good sense where you've just simply never been exposed to something and don't know about it. And there's ignorance in the bad sense where you're ignorant because you have seen this before and you aren't paying attention, right? So ignorance in the good sense of the word is what most doctors have regarding acromegaly. It's a rare condition. They have never seen it and they don't recognize it when it's right in front of them.
Have the needs of the patients changed over the course of your career, Dr. Blevins?
Well, I'm not sure the needs have changed, but I think the opportunities have changed. So what that then translates to is the needs are different because, when I was in my training, all we could do for acromegaly was surgery and radiotherapy. And then amitriptyline was available, and that only worked to control 15% of people, if that many. That's all we had. And then within a couple of years, maybe the second year of my training, the short-acting octreotide was available where you'd have to take it every 8 hours or 6 hours or even by continuous infusion. That wasn't going to work in but a fraction of people. And I've seen these advances in all these different drugs in the past 36 years. That would have all sorts of somatostatin analogs and growth hormone receptor blockers and acromegaly. And the analogs have changed in the formulations and the way you administer them. And the growth hormone receptor blockers are changing a bit and there's future horizons there. So I think the needs of the patient are different because we have opportunities to treat. So patients need to be treated. They need to be on some of these drugs and things like that. So, but I think we're also more aware of the sleep apnea, how to manage that. The need is to get people to sleep specialists to get studied and tested and treated. We're more aware of the hypertension, so the need is to get people on the right drugs, and the need to control the diabetes. All those things are different needs than what we had when I was a trainee in Hopkins in 1990 to 1993. Those same diseases were there, but the needs for treatment are much greater because we have opportunities to treat them.
JD, you talked a little bit about your story. Can
Yeah.
you give us a little more detail about when you were diagnosed?
Sure. The short story, probably we think about 28 years, 30 years,
Yeah, probably.
25.
I looked at photographs.
Yeah, we looked at
Yeah.
photographs.
Here's where it started.
My story is not uncommon, like in, a lot of us, same story. I was having really hip problems and went to a surgeon who I think he had recognized I had it the minute I walked in the room, because he was very careful. And then he showed me, I was doing a hip replacement. He says, your bones are been growing, and there's a condition called acromegaly. Have you heard of it? I said, I know what it is, but I've never heard of it. And that was basically what happened. And he said, you need to be seen now if you have it. So that's when I found Dr. Blevins. And it's just incidental, this physician had experience with a friend of his who was another surgeon that had acromegaly. So he had seen it. So he recognized it immediately. I went back to my primary care doc and said, I need an MRI. This is what I have. And it was like a light bulb came in. That's exactly what Dr. Blevins was talking about. You don't recognize until you're able to put things together. And that was the time when my primary care doc put it together, when I mentioned it. So I was treated, had surgery. My tumor was quite large, so I couldn't resect it, but about 5% left. I'm still on medication every day, and very controlled and feeling great.
The one thing I didn't know about your story is how similar it is to mine. My story started out with me going to the doctor because I had pain in my hips. And my primary care doctor diagnosed me from that point. He said, listen, I'll send you for x-rays for your hip, but I also want you to take an MRI for your brain. And I said, well, doc, I got pain in my hip. Why am I taking an MRI for my brain? He's like, just trust me, just be open to get an MRI for your brain. And I did so, and that came about how my diagnosis came. I didn't know how similar our stories were.
It's amazing. And you probably felt the same way. It was like, oh my God, I'm the only person in the world. And then you learn that there's so many of us with the same kind of a story. May not be hip, but it's sometimes incidental. And I think that's, that was a spark. Wanted to do something. Like I said, how can this be, fact that I'm obviously very long time, but people go 5 to 10 years average when they should be recognized much sooner. We hope the work we're doing, including yours, which is great, by the way, is helping you.
Well, with that said, let me ask you both this question. So, you both have acromegaly. That as a trained physician, I would recognize across the room. If I'd never seen you before, I'd say, these two guys have acromegaly. Yeah. Here we are at an endocrinology conference. And I'm just curious, how many total strangers who are trained endocrinologists, presumably, have come up to either one of you and said, hey, has anybody ever told you you have this disease? Because you'd expect that to happen at this conference.
Yeah.
Has it happened to you?
Once. Yeah.
Once?
I was at the bar at the Hyatt Regency after I got in, and a gentleman came up, sitting next to me. We're watching the basketball game, or maybe the soccer game. And we started talking. So I'm here for a consult. So am I. He says, and okay, sorry. He said, do you have acromegaly, right?
Oh, how about
Dr. Blevins, that has not happened to me.
And I'm shocked.
No.
I would expect a group of endocrinologists to harass you both. Hey, can I stop you for a second and talk about that? but it hasn't. And that's a problem, I think. It's a sign that trained observers should be saying, hey, let me talk to you about this, because that's one way we're going to make this diagnosis sooner. I stop people in airports. I've diagnosed acromegaly in Home Depot 2 or 3 times in the airport, a couple times on the city streets of San Francisco. I just stop people and say, because you know, one time on the minibus, because they may not know it, and they need to know it because they may have complications. I remember stopping one lady in the airport, and she says, "Can you tell?" And I says, "What do you mean?" She says, "Yeah, I have acromegaly. I've had it for 15 years. I'm on treatment with this particular doctor in another city." And she said, "But can you tell?" I says, "Well, that's what I do for a living. So of course I can tell." So I may be the only chance for someone to get an early diagnosis if I stop them on the streets
Yeah.
and tell them. And I think everybody with acromegaly probably ought to do the same. Hey, I have this thing and you look like meat, one of my patients was a bartender, and he was told by one of his clients who's a doctor, "Hey, I think you have this problem called acromegaly. You may have a need to be worried about." So, and he had severe acromegaly and was going to develop terrible complications over time. And, so it does take good Samaritans who know about this condition to do the job that doctors aren't doing. And I'm surprised more doctors here aren't good Samaritans to stop you guys and say,
Yeah.
"Hey, let's."
I don't think that's, I can't remember if I was ever stopped here at the past conferences, but this one was unusual.
And the sad thing is they're missing out on an opportunity to learn about the work that you're doing and the work that you're doing to advocate for patients and for early diagnosis and things like that. So there's a missed opportunity to establish a dialogue and further get this groundswell of knowledge and people working to get people diagnosed sooner before they have to have a hip replacement or a knee replacement, lumbar spinal surgery, or cardiac valve replacement is one of my patients have because of the label.
Yeah, we are here at ENDO 2026. And Dr. Blevins, you are very involved in the endocrine community as a whole. What is your role here at the conference today?
So I'm at this conference for a couple reasons. One, to learn new things myself by attending and listening to people talk. The second is to give talks. I have 4 talks at this meeting, 2 on Cushing's and 2 on diabetes insipidus. And so I'm teaching as well. And then a component of my reason to be here is so that we at Pituitary World News can generate sort of news magazine type little videos of people and their presentations on things that we find interesting on pituitary disease. So, so coaches, tell us about your research, tell us about your project. How does this relate to patient care? What can patients learn from this? And we're doing a bit of that too. So it's a threefold reason to be here. I guess the fourth is just for the social. Sometimes doctors that I've known for 20 years at different institutions where I've trained or practiced, or people that I've trained, I see them once a year at this meeting. So that's the other reason to be here.
I want to take the time to personally thank the both of you. You guys have added my link to my podcast, Talking Acromegaly, with Pituitary with Tony, to Pituitary World News. And I'm thankful for that.
Pleasure. With pleasure, man.
Yeah, it's a great job.
Yeah, it's great to partner with.
Yes,
We really appreciate the work that we're doing.
I appreciate the work that you're doing, and the work that you guys have done has paved the way for me to be able to do the work that I'm doing.
That's wonderful. I'm so happy to hear that, because the more people like you we get involved, and faster this is going to get out, and working together is what it's all about. Thank you.
So the other thing I'll say, and I think both of you are good at this, is it's remarkable how the companies that have developed and produced and marketed drugs for acromegaly, I think have connected with the patient communities. And they do that because they know that we're going to educate the world about this condition. It's not like we're seeking your business. They don't care whether you're on their drug or not. They just care that you're a patient with acromegaly, you suffered, and recognize that you have to help the world be a better place. And I really like that about these companies. That I haven't seen any of the companies that drugs other than what you're on try to convince you to switch over.
Yeah.
And I love that.
Yeah.
because they have the genuine interest in
in
advancing
yeah,
knowledge and
absolutely.
improving quality of
It's
life.
really unusual, I think. Like in people's impression of big pharma, it's so different than the endocrine in this community.
Gentlemen, I want to thank you for your time.
Tony, thank you. It's been a pleasure. It's great.
I want to thank you for joining me today. And most importantly, I want to thank you for talking acromegaly and pituitary return.
Thank you.
You're welcome. Have a good rest of your meeting.
Thank you. You as well.